Imagine a patient comes to the emergency room after a small stab injury just above the clavicle, and the wound looks tiny, but suddenly the patient develops difficulty in breathing. How can injury in the neck damage the lung? The answer lies in the one of the most important but often ignored anatomical regions in the thoracic inlet. And once you understand this concept today, you will never confuse thoracic inlet and thoracic outlet again. And plus, you will be ready for university exams and Viva questions. Before we begin, let me tell you why examiners love this topic. They frequently ask, define the thoracic inlet, draw the label and its boundaries, explain the substance fascia, list the structures passing through the thoracic inlet, and clinical importance of the cervical pleura. If you understand anatomy instead of memorizing it, these questions becomes very easy for you. Let's start with a simple one question that what I ask you, how does the neck communicate with the chest? There must be an opening, and this opening is called as the thoracic inlet. Don't let the name confuse you. Although it's called the inlet, it's anatomically actually upper opening of the thorax, and it acts as a gateway connecting the neck and the thoracic cavity. Every important structure traveling through between the neck and the chest has to be passed through this opening. Think of it is an main entrance gate of the hospital, and doctors, patients, ambulances and supplies all pass through the same entrance. Similarly, nerves, blood vessels and trachea, esophagus and many other structures pass through the thoracic inlet. Now what does the opening look like? It is the kidney shape, not a circular. It is the transverse diameter and about the 10 to 12 centimeter, and anterior-posterior diameter is about 5 centimeter. Why it is wider from side to side? Because the first ribs curves laterally and making the opening broader transversely than front to the back. And students often forget which diameter is larger. Remember, while like a smile, transverse short from the back, anterior-posterior diameter. Now comes the one of the most commonly asked questions instead of memorizing it, and let's build the opening together. Anterior boundary. In front of the boundary is formed by the upper border of manubrium sterni. Ask yourself why manubrium? It is because uppermost part of the sternum. It is the uppermost part of the sternum, and posterior boundary. Behind the boundary is formed by the body of the first thoracic vertebrae T1. So anteriorly we have bone, and posteriorly we have also bone. One on both sides the boundaries are formed by the first rib and its costal cartilage. Let's hear the one memory trick that MRT. M manubrium, R is first rib and T is vertebra. So far we have learned thoracic inlet, its opening, and it is kidney shaped. Widerly it is in the anterior transversely and anterior posteriorly, the bounded by the manubrium, first ribs and T1 vertebrae. Now here's something students often memorize without understanding. The thoracic inlet is horizontal. No, it is the oblique. Why? Because the vertebral column is higher than the sternum. Here is the sternum, it is the vertebral column we will see from the side view. And why? Because as a result, plane slopes forward at approximately 45 degrees. Here one angle, and imagine pouring water on the sloping roof. The water flows downwards, and similarly thoracic inlet is tilted. This is the thoracic inlet, it is tilted, it is manubrium and it is the vertebrae. Here anterior part lies about 3.7 centimeter lower than the posterior part, and this explains why inlet is directed downward and forward. Can you now tell me why thoracic inlet is not horizontal? Exactly, because the manubrium lies lower and first thoracic vertebra lies upper, and here is the distance of the 3.7 centimeter. Now comes another favorite exam question that imagine the thoracic inlet is a doorway, and would you leave the doorway completely open? Of course not. You would cover it, and similarly nature cover the each side of the thoracic inlet with the strong fibrous sheaths that are the suprapleural membrane, also known as substance fascia. What is it? It is a triangular fibrous membrane that covers the apex of each lung and separates the thorax from the neck. Let's understand its attachment one by one. It is the apex of the Here is the apex of the membrane, and now move downwards, and this is the forms base. So remember, apex is at the C7 transverse process and base is at the inner border of the first rib and its cartilage. It is the inlet of the thorax. It is formed bilaterally first rib. And here, now look at what lies above and below it. Inferiorly, it fuses with the cervical pleura, and beneath that it lies with the apex of the lungs. Here is the apex of lung, here is the inlet of thorax, here is substance fascia, and below that here is the apex of the lung. Superiorly, it is related to subclavian vessels and other structures at the root of the neck. So now you can understand the hook. The penetrating injury just above the clavicle may tear substance fascia, and cervical pleura causing injury to lung apex and potentially the pneumothorax. What is the function of substance fascia? It provides rigidity to the thoracic inlet, and during inspiration, pressure changes occur inside the thorax. And without this membrane, the soft tissues at the root of the neck could bulge inward and outward excessively, so it acts as a strong protecting roof. Now, let's discuss about this diagram. It is the transverse process of C7 vertebrae, and this is the inner border of first rib and its costal cartilage. It is triangular fascia called as substance fascia. It covers the apex of the lung. Let's discuss about the next part, structures passing through the inlet. Imagine the thoracic inlet as a main highway connecting neck and the chest, and here food has to pass, air has to pass, blood has to pass, nerve has to pass. So can so many important structures fit through this small opening? How can so many important structures fit through such a small opening? Let's understand it conceptually instead of memorizing it lists. In this previous lecture, we have learned the thoracic inlet and boundaries and substance fascia. Instead of memorizing, here you have one memory trick, that is VLSNM. Remember, VLSNM. V means the viscera, L means large vessels, S means small vessels, N means nerves and muscles. VLSMN. Once you remember these 5 groups, the entire topic becomes easy. In the viscera, what are the most important things in the body needs every second? Air, food. Exactly. Well, that's why the first structure passing through the inlet via viscera, that is the trachea. This is airway. Second one is esophagus. Just behind the trachea is the esophagus, and apices of both lungs with the cervical pleura. And here's the interesting fact that the lungs don't stop exactly at the first rib. Their apices project about 2 to 3 centimeter above the clavicle and the root of the neck. That's why the stab injury above the clavicle can puncture the lung. And remnants of the thymus. In children, thymus is relatively large, and we grow older, it shrinks and it replaced largely by fat. And second one is about the large vessels. Now ask yourself a simple question. How does the blood travel between heart and head? It needs the highways. The highways are the large blood vessels. These are at the right side, brachiocephalic artery on the right side. Later it divides into the right common carotid artery and subclavian artery. At the left side, there is no brachiocephalic artery. Instead of, there are 2 arteries arise directly from the arc of aorta, that are the left common carotid artery and left subclavian artery. Students commonly confuse that right has only one trunk, left has 2 separate branches. Veins are there, right brachiocephalic vein and left brachiocephalic vein. Here is the small blood vessels. Besides the major highways, there are smaller services roads supplying the nearby structures. These include internal thoracic arteries, superior intercostal arteries, and first posterior intercostal veins, inferior thyroid veins. Don't simply memorize them. Understand that these vessels supply the chest wall, thyroid region, and upper intercostal space. and university exams usually ask you to list them rather than explain them. Next, we will see the nerves. Can the lungs, heart, and diaphragm function without the nerve supply? Absolutely not. Let's identify the important nerves. Here is the phrenic nerves, that motor nerve for the diaphragm, phrenic nerves for the diaphragm. Without these nerves, normal breathing becomes impossible. Vagus nerve supplies the parasympathetic fibers to the thoracic and abdominal organs. And here, sympathetic trunks. These carry sympathetic fibers responsible for fight and flight responses. And first, thoracic nerve. It is ascends to the across first rib and contribute to the brachial plexus, which supplies the upper limb. And fifth are the muscles. Finally, a few muscles also pass through this region, and these are the sternothyroid and longus colli. Their main role is related to movements and stabilization of the neck and larynx. Here you have seen all about the inlet of the thorax. Here is the diagram that showing all the structures. This is the manubrium. This is the T1. This is the first rib and its costal cartilage. These are the apex of lungs, esophagus, trachea, thymus, these muscles, and these at the right side only brachiocephalic artery, in the right side only, and in the left side two arteries are there. Here, this is the diagram is simple. Practice 1 to 2 times. Next, we will see about the outlet of the thoracic cage. Every minute your diaphragm contracts about 12 to 18 times. That means at the end of today it will have worked it more than 20,000 times without you even thinking about it. But here's the interesting question, that if the thoracic outlet is called the outlet, why it is most completely closed by the muscles? And why does paralysis of the just one nerve making breathing is so difficult? Let's answer all the questions today. So far we have learned the thoracic inlet. Unlike the thoracic inlet, thoracic outlet is a broad inferior opening of the thorax. And now here are some things students often get confused about. If it's called the outlet, shouldn't it be open? No. Almost entire outlet is closed by the diaphragm, which separates the thoracic cavity and abdominal cavity. And so think the thoracic outlet is a doorway because door is the diaphragm. Let's see the boundaries. Anteriorly is infrasternal angle, and posteriorly body of the 12th thoracic vertebrae, and on each side laterally costal margins formed by the lower lips of the cartilage. Here imagine if there were no diaphragm, the lungs and abdominal organs would lie in the same cavity. Breathing wouldn't be ineffective, and organs like liver, stomach would interfere with lung expansion. The diaphragm acts as a strong partition, allowing the lungs movements and abdominal organs below the function and independently. Here is origin of the diaphragm. Let's see. Imagine a circular tent. The diaphragm is like a dome-shaped tent, and the diaphragm, to make the tent stable, ropes must be fixed all around. Similarly, diaphragm arises from the three regions. First one is the sternal part. It arises from the posterior surface of the xiphoid process, and this is the smallest part. Second part is a costal part. This is the largest part and arises from the inner surface of the lower 6 ribs and the costal cartilages. Whenever you have to take a deep breath, the part helps to expand the thoracic cavity. And third part is vertebral part. This is the strongest attachment because it anchors diaphragm to vertebral column. It consists of the right crus and left crus. 5 arcuate ligaments are there. Crura. Why is the right crus longer than the left? Because the liver pushes right dome on the diaphragm higher, requiring the stronger attachment. Right crus origin has L1, L2 and L3, and smaller part left crus that has origin only L1 and L2. Arcuate ligaments. Now let's understand this. Don't think them as separate structures. Think as the bridges over muscles and vessels. There are five in total. Median arcuate ligament, it joins the right and left crura in the front of aorta. And medial arcuate ligament, they arc over the psoas major muscle. And lateral arcuate muscle, they arch over the quadratus lumborum muscle. And here's the one memory trick, that median aorta, medial psoas major, and lateral quadratus lumborum. Here is the now all the muscles fibers converge them to the center, and but they don't insert the bone. Instead, they insert the strong central tendon, and it is the trifoliate, the three-leaf aponeurotic sheath. It has the one anterior leaflet and two posterior leaflets. The superior surface is fused with the fibrous pericardium, and this explains why movements of the diaphragm influences position of heart. Here's the nerve supply, one of the highest examined point, the phrenic nerve motor supply by the C3, C4, C5 nerve roots. These keeps diaphragm alive. Central part is by the phrenic nerve, and peripheral part by these intercostal nerves, lower six intercostal nerves. That's why irritation of the central diaphragm, such as the from the subphrenic abscess, because referred pain to the shoulder, and because the phrenic nerve also carries sensation from the shoulder region. Here's the openings of the diaphragm. Even though diaphragm separates two cavities, the structures still need to pass between them. The nature solves this by creating openings. Three major openings, that the caval opening contains inferior vena cava located at the central tendon. When the diaphragm contracts, this opening widens and helping venous blood return to the heart. Second one is esophageal hiatus. The right crus of the diaphragm is present there and contains esophagus and vagus nerves. Next one is the aortic hiatus, located behind the median arcuate ligament, contains aorta and thoracic duct. Here's the small openings, superior epigastric vessels, lower intercostal vessels and nerves, subcostal vessels and nerve, sympathetic trunks, greater and lesser splanchnic nerves, left phrenic nerve. Usually asked as a short note or a Viva question, these small openings. Here's the diagram. It is the central tendon, then it is the right dome and the left dome, right and left dome, and right and left crus is there, present is there. Right is long and left is short crus. Costal part and sternal part is present, and these are the openings. Here is the aorta. Whenever you see this diagram in the exams, identify the central tendon first, then everything else become easy to label. Here is the next part. Here's one MCQ for you. A patient develops referred pain over the tip of the shoulder due to irritation of the diaphragm. Which nerve carries the pain? Answer is the phrenic nerve. Congratulations, you have now completed anatomy of the thoracic inlet and outlet and diaphragm conceptually, not by memorizing lists, but by understanding why every structure exists and how clinically it's relevant. Thank you.